Now let's talk about second line a little bit. So you were talking already about imetelstat. I think it's great, right, to have a second agent for our patients. I think we're asking now questions, what is an ESA failure? What is a luspatercept failure? When do you make this kind of transition? So why don't you walk us a little bit through that? And tell us a little bit about imetelstat also.
So, I mean, as people that are watching this might know, imetelstat is now the first of its kind approved in what we call, ESA failures. So patients who have had ESAs, luspatercept, maybe other therapies, but not HMAs, that was not explored in the trial, and still continue to need transfusions. And so this drug is now approved for that indication. I agree with Tiffany. We were part of the trial and we are very aware of some of the toxicities. And I think for me personally, the thrombocytopenia is concerning, which happens pretty quickly after that first dose because our patients are older. The SF3B1 and the ring sideroblast patients live longer. We don't know why. They need more transfusions. And so it's a little intimidating to give a drug and then the patient's platelets go from 150 to 50 in an 80-year-old. And so I love that there's an option, but there was no option in this space. In the US, the go-to was HMAs, and you've done some of the pioneering work with low-dose HMAs in this space, and I think they are very effective. So the typical patients, once this indication was approved in my practice, are patients who've seen everything. And they've seen HMAs, which we have some data on, but not a lot of data. They were not enrolled in the study. So the patients that we've been giving this drug to have seen everything. And so we are learning how to use the drug, how to manage the toxicities. We've had few patients on this drug so far with mixed results. So I'll just stop there and see what other people think.
Limited experience with the compound exactly for the same reasons that you're talking. Also, maybe this may resonate with Amy a little bit. We're concerned with targeting telomerase activity in this disease. I mean, but at the ASH meeting, there's a very nice presentation suggesting that maybe ferropoptosis is actually the true mechanism by which this drug works. So maybe, we don't know how HMA works. And actually, I'm not sure that we 100% understand how luspatercept works. But that, to me, was kind of concerning. Mm-hmm. Like blocking this enzymatic activity, I don't think is really that positive. But it works. And I think now we're starting to ask these questions. ESA failure, luspa failure. And we will learn how to use this. And I think it's great that now that we have a really powerful frontline approach, we have second line. I think we need to learn actually what really happens to luspatercept failure treated with imetelstat. Dr. Platzbecker had presentation Saturday with some of this data. I need to, understand it a little bit better.
I think we really, on some hand, I feel like sometimes I'm arguing out of both sides of my mouth. I think everybody should start earlier so they feel better longer, but then I'm very hesitant to start something like this earlier. But given the mechanism of action and the cytopenias and the toxicity, I think holding it to multiple lines later may mean the marrow failure component is really burning out for a patient. And at that point, inhibiting telomerase activity probably is detrimental. And I think we need more real world experience because biologically, even though we haven't seen it, you could imagine if you continue to inhibit enzymatic activity and shorten the telomeres, we may end up with other malignant problems that we are not keen to see. And so I am sort of being quite measured and selective in my patients. And then I have very open, informed consent with individuals because I think a lot of older patients have the concern of exchanging red cell transfusion dependence for something like platelet transfusion dependence, which somehow seems worse. And so that's
No,
tricky.
I agree with Uma. I mean, you could die from an intracranial bleed. So I think this is the cytopenia that makes us the most concerned.